Hello, good morning. I'm going to present the 79-year-old male. He has a story of hypertension, diabetes, and dyslipidemia, and he had a previous ictus. He also has severe kidney disease. In April, he was hospitalized with the diagnosis of acute heart failure with severe dysfunction of the left ventricle. In the electrocardiogram, he has a left bundle branch block, and in the blood test, he has a 2.9 milligrams per deciliter of creatinine, which corresponds with a glomerular filtration of 26. During the hospital stay, a coronary angiogram was done, showing severe ischemic coronary disease. He has a severe disease of the proximal anterior descendant artery, and he also has a severe disease of the circumflex in the distal zone. We also see that the right artery has disease in the descendant posterior artery. The syntax score was low, about 18 points, but the Euro score and the STS mortality risk score is very high, about the 18% of risk, and that's why we are going to do the revascularization by percutaneous revascularization. So we are going to do also a low contrast PCI guided by IVUS, because the severe kidney dysfunction that the patient has, and we are going to support the angiography angioplasty, by an intra-aortic balloon pump because of the severe dysfunction.
Our decision, after talking about the case with the colleague, we decided that yes, this is a high-risk patient. No, we said before that he's over 75. He has a chronic kidney disease. He has had a previous stroke. He has a reduced left ventricular ejection fraction, and the anatomy, it's the one that we saw first. The more proximal vessel is the left anterior descendant artery, and then the lesions that we see in the circumflex artery and in the right coronary artery are a little bit less proximal. So that's why we finally made the choice of supporting this procedure with an intra-aortic balloon pump.
So we are trying to perform the multivessel vascularization, but starting from the left tree, and only if we are able to complete it with less than 40 or 50 cc of contrast, we will continue with the right coronary artery. The more tricky lesion, in my opinion, is the left anterior descendant. You have seen the angios before. We are doing some more angios now because it has some tortuosity. It's a calcified lesion. It's also a bifurcation, but the side branch is occluded. So we are going to forget it and trying to minimize the contrast volume. And we are trying not to use the atherectomy devices because of the left ventricular dysfunction, and try to see if with semi-compliant or non-compliant balloons, the dilation, the expansion is okay. So now the setup, we have the intra-aortic balloon pump to the left femoral artery, echo-guided puncture is working now. And we have a radial approach, a slender sheath 7 French with an EVU 7 French in the left main. We have crossed 2 wires, a cyan blue wire that is our Warhawks one in the circ that cross indeed to the lesion we are going to treat. And struggling a little bit more during the speech of Sandra, I crossed cyan black to the distal LAD, as you can see here. In these cases in which we aim to perform a low contrast PCI or ultra low contrast, there are also colleagues that are doing 0 contrast PCI, but I think it's just an exaggeration and it's magic, no? We are trying to start with the LED, Guillermo, or the circ?
No, I think the LED is
Our initial plan was the LED, but we crossed before to the circ and was tempted to start with the circ. So let's try to predilate a little bit because the IVUS is not going to cross. So please, 1.5 or Guillermo?
okay.
Un balón de 1,5, porfa.
I think that is important that the contrast is visipaque. That is a isomolar contrast. No, I think it's better for the kidney that the other.
You rate 1,5, 10.
We always use a visipaque contrast from General Electric, and I think it's very, very good for interventional cardiologists.
No, for this patient to perform a low contrast and protect the acute kidney injury, that in this patient with chronic renal failure, the rate of acute kidney injury goes up to 30%, and it impacts in mortality and other MACE. There are several tools you can use. Of course, IVUS for me is the main one to guide the procedure with IVUS and avoid unnecessary injections of contrast. Also, that Guillermo said, use low osmolar contrast media.
This is osmolar.
Yeah, or hypoosmolar, it depends, but it's true. And another tricks are, of course, to delay the PCI, not doing at the same procedure of the diagnostic angiogram. Use this previous angiogram as a roadmap to avoid more injections the day of the PCI, and also to use this metallic roadmap with the wires in the side branches or whenever you want to avoid contrast. So we are going to see if the 1.5 balloon cross the tight lesion, the tight and the calcified lesion of the LAD. And after this inflation, we are doing IVUS. If we thought the IVUS could cross initially, we have done it, but in this case,
14.
I'm pretty sure that the IVUS cannot cross with this critical lesion. Okay. If you are seeing the hemodynamics, the intra-aortic balloon pump is doing its
14?
job. 18.
18.
Okay. Another more proximal, the last one. Okay. There. Yeah, this is from EM to EM. Probably I would go, I don't know. I will be more conservative, probably, and then post-dilate if we can. So let's try with an uncompliant balloon.
Non-compliant, no?
2.5.
Or 2.75.
2.75, non-compliant balloon, please.
2.75.
And the length, Laura, yeah? Probably 40 something or what? 45. Yeah.
18.
18. I think the expansion is okay. This is not the more calcified plaque. In the next inflation, we are going to confirm in 2 orthogonal projection that the expansion is good. Okay.
Can we use a bigger balloon for the proximal LED or?
Yes, we can do it. 3.5.
Okay.
Balón 3,5 NC. Ok, dale. So let's choose the stent. Everything is okay. The ECG, the blood pressure. This is the distal portion probably is there, probably some dissection there. The vessel has improved a lot. I think the diameter of the vessel has improved a lot. And after this run, we can decide if we need more plaque modification or going for the stent. Yeah, it's 3 more or less. So we can, my only doubt is if we can cover all the lesion with a 48 stent, probably not. With this measurement, 52 millimeters. So the question if using 2 overlapped stents, so only 1, of 60. This morph tapered stents. Probably because of this tortuosity and calcification, I think we can use a 3 point something for the mid part of the vessel and a 3.5 just to have more options to overdilate the proximal part.
Yeah.
So this is a morph stent, 60 millimeters in length, 3.5 in the proximal part, and 3.0 in the distal one. As Guillermo advanced, the stent is advancing with some struggles, but quite well. And I think we are almost there. Okay. Okay. I think we are there.
Okay.
Let's go. We have the wire in the circle as a marker, and we are covering all the proximal part of the LAD just to nominal pressure.
Just it's 10.
Just
only 10.
I'm concerned of the distal part of the
10.
go down because the patient does not tolerate so well. We are now post-dilating a little bit the proximal part of the stent with the 3.5 balloon we used before. From here.
Yeah.
We are going to post-dilate the distal part of the stent, not the distal end, no, just in the middle, with a 3.0
in distal, no, but inside the stent.
Inside the stent, okay. Okay, you see the expansion here is quite good. The most problematic part is the mid part of the stent. Yeah. And we have post-dilated a little bit with the 3.0, okay, 20 atmospheres with expansion, and now this is the more tight one, I think, the most underexpanded part. But as you can see, it's not bad, okay? Okay, let's do IVUS now. Let's check if is there any dissection or something at the distal part of the stent. There is no dissection. The expansion is good. The position is good. This was the less calcified part, I think. Yes, the stent is not a circle at the more calcified plaque, but if the minimal stent area is over 5 or something like that, I think the result is quite good. The proximal part of the stent is also okay. There, I think is but for sure over 5 or 5.5. I think we're done here.
Yeah.
So let's go for the circ.
Yeah.
So the result of the lady is quite good. We are not injecting any more contrast here because we have the IVUS that confirm it. So we are moving to the circ. A little bit more. Poco más. Okay, we are there. Can we have a 2.0 balloon?
Yeah.
Un balón de 2, porfa.
Vale.
Sí, venga.
Vale.
We are using a 2.0 non-compliant balloon.
15, no?
15.
Yeah.
What you're seeing is a calcified plaque.
18.
Okay, a calcified plaque with more tortuosity than the LAD. I think it has crossed a little bit more.
Also.
You can see the expansion quite well. And the balloon is crossing very nicely now. I will do the last one here.
Yeah, probably yes.
Redilate everything going backwards, and then IVUS here.
18.
I think it's under expansion there. Probably.
I'm not sure.
I'm not sure about that. Let's try with an NC 2.5. No, the 2.5 balloon goes much better than before. Probably there.
12.
Okay, I think the expansion is nice. Okay, another one.
16.
No, this is a good expansion, in my opinion.
Yes,
Okay.
yes, it's okay.
Let's go with the IVUS. I have maintained the wire in the LAD, not using it at the distal circ, because the EVU is getting inside the circ very deeply, and we don't want to reduce any dissection or anything there. So I'm using the wire in the LED just as a security tool. So let's go with the IVUS.
Can I see the IVUS?
No,
Okay.
we have the flex vision here, and we are changing this reference for the IVUS.
Yes.
Yes, Pilar is asking us if we have put only one stent in the LED, but it's a stent of 60 millimeters. So it's like 2 or 3 stents, conventional stents. Let's see the IVUS cross because it's so tortuous. I think it's crossing, and probably I am near the distal landing zone. Probably a little bit far there. Okay, it's a small vessel here, probably 2.0. Out of plaque there, some calcification, but not severe at this point. Here the vessel is bigger, some dissection after the dilatations, more calcified here. Here, but I think there are some fractures there. And this is the proximal part and the branch. Okay. This is the proximal circ. Okay, we can stop here. Let's go out. Can we check it, Laura? B1 is the distal, right? At this, okay. And the length?
Es 220 es la luz. La capa media yo creo que es un poquito.
Ya, pero hay que ser.
2,5 igual entra, ¿eh? Lo digo porque arriba es más. Arriba ya sí que. ¿No? Arriba.
It's a very long distance. I don't know if we have to cover everything. We have some debate here because the previous angio, the length is, in my opinion, near 30 or 30 something. Yeah, and the initial IVUS measurement said that it was nearly 50.
2,5, 38, 48, 2,5.
38 quizá, ¿no?
38 yo creo, ¿no? Yo por lo que veo aquí.
And the distal bookmark, please, just to check the. Can we have a synergy stent 2.25, 225, 38? Probably there. Okay.
It's close.
Okay.
It's close. Okay.
Let's implant here. And we have a 2.5.
This is 2.5. Okay.
No, this is 2.25, and we have a 2.5 to post.
Yeah.
Even a 2.75, I think.
12.
I think the expansion is quite good.
Yes, 12 is nominal value. Nominal pressure. Sí, hay una medio ahí.
We're going to post dilate with a non-compliant balloon. The proximal part of the stent.
Bueno, voy a pegarle aquí 20, ¿no? Porque esto ya es la parte proximal.
Okay, I think the expansion is quite good. Let's retrieve the balloon and do IVUS to confirm.
La parte proximal, sí.
Sí. In the meantime, we have done the IVUS. Laura is measuring the MSA. In general, the stent is okay. The distal edge of the stent is okay. There is no dissection. This is the MSA probably. near 5, but this is a smaller vessel than the LED. I think over 5 is a good result. This small vessel, you have to take into account the
I think it's good.
I think it's a good result. I think it's a good result near 5 in a vessel. The distal part is near 2.25. So I think we are done.
Podemos hacer una bien, ¿no? Nice.
Very nice.
It's very nice, no?
Okay, let's go.